Hello, everyone. This is Abdeh Hussain, and today we have our 12th presentation of Critical Care Forum, the dose adjustment and renal and hepatic failure. Such an important topic in critical care, as we see day in, day out, so many patients maybe having an AKI or hepatic failure, liver cirrhosis, or maybe a chronic kidney disease case. And complicated with so many things, other comorbidities, and there are so many drugs going on, and plus additional drugs that we need to add in ICU. So it becomes a really tricky situation for a clinical pharmacist to adjust those doses and remember the drugs that require the dose adjustments in each individual cases so that an optimal dose is achieved and also the adverse effects related to the toxicity because of their accumulation can be circumvented. So today, I would like to introduce Mohammed Irfan, who will be speaking more about this topic. So let me tell you more about Irfan. So he's a dedicated critical care clinical pharmacist working at ICRA Hospital, Calicut. He has experience of more than 1 year in critical care. He had the privilege of speaking at the ICCPS and the ACP 8-layer conference hosted by ICRA. So without further ado, Mohammed Irfan, I would like to hand over you to begin the session.
Thank you, Abdi, for the warm welcoming and the introduction. So I would like to start with the topic that is the dose adjustment in renal and hepatic failure. And first, the learning objectives are, which would I like to convey through this slide is identifying markers for renal function, calculation of creatinine clearance, and criteria for drug dosing in renal failure, that is in AKI, that's acute kidney injury, and the CKD. Then identifying the markers for hepatic function, and at last the criteria for hepatic dose adjustments. And first of all, we can look on to the organ, that is the kidney. They are the pair of organs that are found on the either side of that is our spine, just below the rib cage in the back. It is an important organ in regulating, that is the body fluids, electrolytes, and balance removal of that is metabolic waste and the drug excretion from our body. The impairment, that is the impairment or regeneration of our kidney function affects, that is the pharmacokinetics of our drugs, that is which we are taking. So the most common cause of kidney failures, which includes mainly three things, that is diseases, direct damage to the kidney, and at last, not the least, which is drug induced. And it is a simple anatomy, or you can say that as in complicated anatomy of the kidney, which we can see the medulla, cortex, renal artery, and at last the tubule-like thing is ureter. And we can look on to the renal failure. What is renal failure? And in the coming slides, I will tell about the definition, classification, and also the causes. First of all, what is renal failure, or can also be called as renal insufficiency? It is a medical condition in which kidney fails to filter the toxins or waste products from the blood. That is, renal failure usually describes, that is the decrease in the GFR, which we can tell it as the glomerular filtration rate. And the usual symptoms which we can see when the renal failure occurs is generalized malaise, nausea, vomiting, dependent or generalized edema, or decreased urine output. Next, we can move on to the classifications. It can be, simply we can divide into two, that is acute renal failure, that is AR, and which is chronic renal failure, which we can say it as the abrupt increase in the serum creatinine, which is more than 0.3 mg per deciliter within 48 hours, that is within the 2 days of gap, or similar increase over a few months or weeks. Then we can move on to the chronic renal failure, that is, it is a progressive loss of function over several months to years, which is characterized by the gradual replacement of the normal kidney architecture with interstitial fibrosis, that is the damage to the kidney cells. Okay. And we can move on to we can look onto the KDIGO classification, that is KDIGO classification, which is a kidney disease improving global outcomes classification. They also say it as I have said in the previous slide, what is AKI? That is the serum creatinine increasing by more than 0.3 mg per deciliter within 2 days, that is within 48 hours, or becoming oliguric. In structural criteria, there is no structural or no criteria within that. And the CKD patients, we can sell it at the decrease in the GFR, that is the glomerular filtration rate. The normal GFR is, that is 130 ml per minute per 1.73 meters square, that is surface area. And here the GFR is below 60 ml per minute per 1.73 meters square, that is more than for 3 months. And the structural criteria here is the kidney damage for more than 3 months. And we can look onto the AKD. This is a GFR that is less than 60 ml per 1.73 meters square, that less than 3 months. And NKD is GFR, that is no kidney disease, is more than, that is 60 ml per minute, or we can call it as in the stable serum creatinine level. Okay, it is the same as the National Kidney Foundation Kidney Diseases Outcomes Quality Initiative has also classified the GFR categories in the CKD, that is the G1, G2, G3A, and G3B, and G4, G5. They have classified according to the GFR range, that is the glomerular filtration rate. And also they have given the clinical presentation, which we have said in the previous slides. But when we look on to the mild to moderate situations, or severe situations, they have given the mild to severe complications, that is anemia and cardiovascular diseases like hypertension and lipid abnormalities and low serum albumin. And the most prominent in the kidney failure, we have given as uremia, urea increasing conditions, and the 5 stages of kidney disease. And the next, the common causes of renal failure. The most common causes we can rule it out is, first one is hypovolemia, that is any condition that is reducing the renal blood flow to the kidney, that is in the sepsis like conditions. As we all know, first, if we have a shock or something like that, which is related to the critical care, the first organ which will affect the shock is kidney, because the renal blood flow will be affected. As part, the creatinine level will be increased, and also it will affect the output, urine output. Then the second one is diabetes mellitus, that is the disturbance in the sugar metabolites, and the sugar metabolism may lead to the regenerative renal diseases. The next one is a hypertension, that is chronic overloading of kidney with the fluid, and its accumulation with the fluid. Then the electrolytes lead to kidney insufficiency. Then the next one, which is nephrotoxic drugs or metals, which I am going to tell in detail in the next slide. Sorry, 1 minute. And next one is the pyelonephritis, that is the inflammation of pyelonephrons. And which I have said in the previous slide, that is drug-induced AKI, that is which we can be divided into 3. That is a pre-renal, renal, and post-renal. And last one, the bladder obstruction. The pre-renal, which we are giving, is the hemodynamic alterations, in which if the renal vascular resistance has been increased with some drugs like NSAIDs, COX-2 inhibitors, cyclosporine, and tacrolimus like immunosuppressants. And we have transcapillary pressure decreasing, that is example by ACE inhibitors or by ARBs. As we will inquire in the medical reconciliation, will be thoroughly giving or getting the which one their history. So AC and ARB. And the real intrinsic in the intrinsic situations that we will look on to the acute tubular necrosis like situations, which in the drugs like amphotericin B, you know that and it is an antifungal which is coming under the polyenes. It is very underwent the tubular necrosis. This is very toxic. It have been 2 types, that is conventional and also liposomal. The conventional type, it is very more nephrotoxic when compared to the liposomal. So it is, when compared to the liposomal, it is less costly, and in the liposomal it is more costly. So it have only less side effect in the liposomal. So in the severe AK condition or CKD conditions, we can go on for the liposomal amphotericin B. When we are giving the conventional amphotericin B, we should hydrate the patient very well. Then we can, at most, we can inquire about the acute tubular necrosis. And next, the acute interstitial nephritis, which is mostly by the antibiotics like penicillin, cephalosporin, sulfonamides, and ciprofloxacin. That is the fluoroquinolones, and also the vancomycin. Vancomycin also nephrotoxic, as you all know. And the next one is glomerular nephritis. It is also caused by the NSAIDs and also antimicrobials like penicillin, penicillamine, and rifampin. And next one is the post-renal, that's next category. It is also precipitation of drugs in the renal tubules. It is like sulfonamides, methotrexate, sulfodioxin, and vitamin C, which is in the larger doses, that is toxic doses. And the blood, and the last one, which is bladder obstruction, which is mainly done by the anticholinergics. And next one, how we can measure the kidney function. It is very important to measure the kidney function. As we all know, we should adjust the doses of all the drugs which are using in the ICU, that is the critical care unit or outside the ICU, according to the kidney functioning. If not, it will accumulate in our body and it will be more toxic for our body. And the measurement of GFR. As the GFR is a widely accepted as well as the best overall measure of kidney function, and the several drugs and endogenous substances have been used as markers to measure GFR, that is a creatine. These markers carried to the kidney by the kidneys via, which by what? It is by renal artery, and are filtered by at the glomerulus. That is the changes in the GFR, it will reflect the kidney function also. You should know that. And the measure of GFR, creatine clearance. The clearance of creatine is used most extensively as measurement of GFR. And in humans, the creatine is filtered mainly at the glomerulus by tubular reabsorption, and it tends to decrease in the elderly patients, that is above 60 or 65. And the creatine clearance, mainly, the creatine clearance may be defined as the volume of plasma cleared of creatine per unit time. That is, I have given the equation, that is the CLCR is equal to rate of urinary excretion of creatine divided by the serum creatine concentration. It is expressed mainly, that is in ml per minute. And the serum creatine concentration and creatine clearance. Under normal circumstances, creatine production is roughly equal to the creatine excretion. So the serum creatine level is the constant. But in certain cases, it will be altered. That is, in patient with low reduced glomerular filtration, or serum creatine will accumulate in accordance with the degree of loss of glomerular filtration in the kidney. And what is the limitations of serum creatine? We should know that is a patient with fluid overload has low serum creatine due to what? The dilution of the blood. And the malnutrition or inactivity decreases muscle mass. That in the most prolonged stay patients in the critical care or in the hospital, they will be having only a low muscle mass. The protein intake will be very less. So the malnutrition and inactivity decreases the muscle mass, that is in the bedridden patients. Thus, decrease in serum creatine can be shown in that patients. A small fraction of serum creatine is actively secreted through proximal tubule, and the active secretions can increase in renal diseases, giving overestimate of clearance, that is than inulin clearance, even up to 2.5 times. And drugs such as cimetidine, trimethoprim, corticosteroids, pyrimethamine, phenexamide, salicylate, and active vitamin D metabolites can block active tubular secretions of serum creatine and increase the serum creatine. And diseases interfere the GFR, that is high blood pressure, DM, that is diabetes mellitus, and congenital heart failure, and diseases of transplant kidney. And how we can calculate the creatine clearance. It is very, very important. How we can, what are the methods? There are three methods mainly. That is the Cockcroft equation, which we are using in our critical care unit, and mostly used equation in all over India. And next one is MDRD. And next one is the third one, that is CKD epidemiology collaboration. And the Cockcroft and Galt method. The first one, the Cockcroft is used to estimate the creatine clearance from serum creatine concentration. Using of body weight seems logical in the equations, and the creatine clearance should be based on the IBW, that is the ideal body weight. And for obese patients, if it is more than 20% our ideal body weight, in obese patients, we will take adjusted body weight. And first one is the Cockcroft-Gault equation, that is in the males. The IBW can be measured by 50 kg, that is 50 kilogram plus 2.3 kg for each inch over 5 feet. And females, it is for in males we have said that 50 kg, here 45.5 kg should be taken. And the adjusted body weight can be measured by ABW is equal to IBW plus 0.3 into total body weight minus ideal body weight. And here I have given the equation of Cockcroft, that is the 140 minus patient's age into body weight into kilogram divided by 72 into serum creatine in mg per deciliter. If it is taken in females, into 0.85 should be added into that in the calculation. And next one is a modification of diet in renal diseases, that's MDRD. That is, this equation is generated mainly from, that is developed from the sample of patients with CKD using the creatine clearance of iothalamate 125. It is not using much in the Indian scenario. And the next one is the CKD epidemiology collaboration. It is also not much used in the Indian scenario. It is based on the 4 variables, that is the serum creatine, age, sex, and race. So how we are dosing, that is modifying the dose of drug in case of ARF, that is acute renal failure. The drug dosing in critical ill patients with AKI has been problematic. Several issues are unique to this population, including a rapid change in serum creatine, the time needed to reach a new steady state concentration, and influence of aggressive volume resuscitation in that it will increase the volume distribution, and the increase in creatine secretion in early AKI, and increase in non-renal clearance, and also influence of renal replacement therapies, that is RRTs. And dose adjustment in the CKD. As we should all know about that, in the CKD patients, the loading dose of the drugs should not be adjusted. And some guidelines suggest that for maintaining dosing adjustment, dose reduction, and lengthening the dose interval, or both. Dose reduction maintains a more constant drug concentration but associated with high risk of toxicities if the dosing interval is inadequate to allow for drug elimination. Lengthening of dose interval, that is lower risk of toxicity but a higher risk of subtherapeutic concentration. The effectiveness will not be achieved in that kind of patients. And I will give a case scenario, that is Sam. A patient with 68-year-old, 70 kg, 70 kilogram patient, a man admitted to ICU with fever, elevated WBC, and respiratory failure requiring mechanical ventilation and norepinephrine, that is noradrenaline, to support his blood pressure. His medical history is significant for chronic back pain, for which he takes acetaminophen as needed, diabetes for which he takes glipizide, and enalapril, that is ACE inhibitor, for hypertension. And before this admission, his blood pressure was 140/80, and the HbA1c was 5.2, and WBC 5.0, and the blood urea nitrogen is, that is 7 mg per deciliter, and serum creatine is 0.9, and today his WBC is 24,000, and blood urea nitrogen is 38, and serum creatine as elevated to 3.2, and with about 325 ml of urine output since his admission 24 hours ago, that is a 1 day urine output. Which medication is more likely contributing to the acute kidney injury? That is enalapril, glipizide, acetaminophen, and at last enalapril or glipizide. We can look onto that. Which medication? That is the answer A. Which is the answer A? That is enalapril. That is the ACE inhibitor. The SAM has, that's why it has been answer A. I will give the explanation. SAM has at least severe sepsis that led to decreased renal perfusion causing AKI. And enlaple likely contributed to the injury by altering the renal hemodynamics. Both glipizide and acetaminophen is less likely to cause AK, that is acute kidney injury. And the second question from that case scenario, that is when evaluating the SAM potential causes of AK, which additional information or test would be important to consider or obtain? That is A, weight loss, symptoms, and coexisting diseases or medications. And the B, that is renal evaluation using USG, that is ultrasonography, because this can determine the cause of AK in most patients. And the third one is review of blood chemistries, because this will likely to determine the cause of injury. And fourth one, the renal evaluation using biopsy. And we can look on to which one is the most apt one. That is, it is also an answer A, that is the evaluation of the comorbidities or condition disease like conditions. That is the explanation. I will give the explanation. The acute kidney injury cannot be diagnosed with a specific test of study. Patient's rate of kidney loss, symptoms, and coexisting diseases are very important. As I have said in the first of the beginning of the class, that the taking, that is a reconciliation, is very important in these cases. That is the previous medication and medication history and medical histories are very, very much important in these cases. And drug-induced AK is most common in the setting of additional results and may occur even after the drug is discontinued. And drug dosing in renal patients. And in the antifungals, I will mostly the fluconazole has been seen. If the patient is having the creatinine levels that is below 50, 50 GFR is below 50, then the reduction of the fluconazole should be 50% reduction of the determined dose should be done. And in the antivirals, acyclovir is very much important. Only in the frequency, that is the 100% dose should be administered, but in the frequency, the changes have been determined, as in we should be implicated. That is implemented in the or in the patient. And in the carbapenems, the most used carbapenem nowadays is the meropenem. As if the patient we should we should take a cutoff in the patients. That is, if the patient is having creatinine clearance less than 50, that is 50. If the patient having the normal dose 1 gram TID, which I have put in for a normal dosing patient, and if the patient is having creatinine clearance, if it has become less than 50, in between 25 to 50, we should adjust the dose according to that. There's 1 gram BD should be given, and according to the grams, if it is 20 below 25, we should adjust 500 mg BD, and if it is less than 10, we should give it as 500 mg OD. So it is very much important to know that is what is creatinine clearance in between that. And I have given the list of cephalosporins, macrolides, and penicillins. In the azithromycin, and the macrolides, that is azithromycin, no dose adjustment is necessary. And it's the last, the penicillin groups, the quinolones groups, and in the quinolone groups, as the ciprofloxacin, levofloxacin, in all that, creatinine, according to creatinine dose should be adjusted. And next one is RRT, which is very much important in the critical patients. That is a renal replacement therapy for reversing AK or metabolic control, and patient volume should be followed closely in the first line. And RRT should only be initiated only when other approaches have been failed. So it is a last approach. You should all be thoroughly note that for reversing AK, it is not the first approach, it is the last approach, that is RRT. So RRT has been offered when if the patient is having severe acidosis or electrolyte abnormalities, that is the hyperkalemia is present, and settings of certain intoxicates, refractory volume overload, or symptomatic urea, RRT should be initiated. That is the recent evidence suggests that the early initiation of the RRT is very much important for decreasing the mortality rate also. And the modes of RRT are, that is intermittent hemodialysis. Different modes of RRT include IHD, that is intermittent hemodialysis, then peritoneal dialysis, that's PD, and CRRT, that is continuous renal replacement therapy, then EDD, extended daily dialysis, and SLED, that is sustained low efficiency dialysis. It is very much important which dialysis or which RRT is initiated. According to that, that is the antimicrobials and the which is the drug should be adjusted according to the modes of the RRT. And the second one is solute and water transport through semi-permeable membrane assist in defining the mode of RRT. Solute removal requires that is diffusion, convection, or its combination. And the next one is the continuous, that is CRRT. CRRT is most commonly used modality of RRT in hemodynamically unstable patients. That is, now in this scenario, the CRRT has been used in very much in critical ill patients. It is very much evident in that patients. CRRT modalities, that is very CVVH, continuous veno-venous, that is CVVHT, and CVVHDF. The CVVHT means continuous veno-venous hemodialysis, and VVHDF means continuous veno-venous hemodialysis, hemodiafiltration. So solid clearance during CVVHD occurs by diffusion, and solute clearance by CVVH occurs by convection. And CRRT and drug dosing concepts, which is our responsibility, and we should look on to that. Drug properties that influence removal during CRRT include protein binding, molecular weight, and VD. As we all know, if a drug is very much binded, that is bound to proteins, it is non-dialysable. Dialysability is very much less. If it is less accumulated or less bound to protein, it can be easily dialysed. So as I have said in the second point, is that removal is inversely proportional to the percentage bound. The higher percentage bound, the less is removed. In the absence of significant protein binding, the molecular weight of most drugs has little impact on overall clearance. As molecular weight increases, clearance is reduced. So we should know that if the drug is having low molecular weight, the drug will be, as in the recently I came with a case of cyanide poisoning, and we have given sodium thiosulfate, and in that patient, it is sodium thiosulfate is small molecules. So the patient is also want to initiated by the plasmapheresis, but the sodium thiosulfate removed 50% removal is by plasmapheresis, that is hemodialysis, dialysis. So after that, we again given a dose of sodium thiosulfate for getting an enough concentration in the blood of that patient. And next, the CRRT dosing, and I have given an article-based dosing on that. That is the common antibiotics, which should be adjusted according to the CRRT, and dose according to the CVVHD. That is according to the dialysis flow rate, the dose should be adjusted. So you should look onto that, how the dose should be adjusted. It is not like the hemodialysis patient. It is different for the hemodialysis patient, intermittent hemodialysis patient, and also for the CRRT patient. And next, I have completed. I will came up with the, that is the renal impairment patients, and next is the liver failure. We can move on to liver failure. And the liver failure or hepatic insufficiency, it is the inability of the liver to perform its normal synthetic and metabolic function at part of the normal physiology. As you all know, the main organ which take place the metabolism of drug is liver. That you have studied the metabolism, which is by enzyme, that's microsomal and non-microsomal like enzymes, and the enzymes like cytochrome P1 and 2, 3, and the most of the 50% of drugs have been metabolized by the cytochrome 3A4 enzyme. And the liver failure can be classified into two, that is the acute liver failure and the chronic liver failure. And we can know the definitions, how we can differentiate the acute and chronic liver failure. The acute liver failure mainly defined as the rapid development of hepatocellular dysfunction, specifically coagulopathy and mental status changes in patients without prior liver disease. And the chronic liver diseases it usually occurs in the context of cirrhosis itself, potentially the result of many possible causes such as excessive, that is alcohol intake, hepatitis B or C, autoimmune and hereditary and metabolic causes. And the anatomy, there is a liver diseases, sorry. And next, the liver receives, that is approximately 30% of the cardiac output. Uniquely, it receives both arterial blood from the hepatic artery and venous blood from the portal veins. Portal vein supplies, that is 70 to 75% of hepatic blood flow, but 50% of oxygen supply. The remaining blood flow and oxygen supply from hepatic artery. Anatomically, liver is divided into two lobes, that is two lobes. and further into function log based around a central way. So the functions are the metabolic, synthetic, and storage. Metabolic, in the metabolic functions, mainly the gluconeogenesis, deamination of ammonia to form urea, then is triglyceride and cholesterol, and next is bilirubin, and the conjugation to form, that is water soluble. And in the synthetic functions, that is the production of clotting factors, antithrombin, bile acids, plasma flow, that is cholinesterases, and albumin. And next one is the storage of some vitamins, that is vitamin A, D, K, vitamin B12, that is cyanocobalamin, then folate, glycogen, iron, and copper, that is Cu. And we can know the etiology, how the damage is, what are the etiology behind the liver damage. The liver can be damaged in a variety of ways, that is, cell can become inflamed, such as hepatitis and hepatitis, and bile flow can be obstructed, such as cholestasis. And next is the cholesterol or triglycerides can be accumulated. The term is thus steatosis. And next one is the drug induced. And what are the consideration in with hepatic impairment? As a drug elimination, drugs can be eliminated by the liver. That is more than 20% are less likely to be affected by liver disease. And the protein binding, drug protein binding may be altered due to alteration in the hepatic synthesis of, that is mainly by albumin. And therapeutic range, that is the drugs with a wide range, will be less affected by the moderate hepatic impairment. And what are the main hepatic markers when which we look onto? That is mainly the aminotransferase, that is the AST. Next one, the alkaline phosphatase, then bilirubin, and prothrombin type. And we also do a scoring system in the CLD patients, that is in cirrhotic patients. That is if the parameters, that is we will give SITS, bilirubin, albumin, and prothrombin time and encephalopathy in the Child-Pugh classification. And if the point is in between, that is 10 to 15, it comes under Child-Pugh score C. And if it is in between 7 to 9, it comes under Child-Pugh score B. And if it comes under A, that is in between 5 to 6, it comes under classification, that is class A. So some of the drugs, that is, if I say the antifungals, echinocandins, caspofungin, we will adjust the dose according to the Child-Pugh scoring system. Normally, in a patient, we will give the caspofungin, the loading dose as 70 mg, and we will adjust the dose for CLD patients. But normally, we will give the maintenance dose 50 mg. But in the CLD patients, if we look on to the CLD, that is what a Child-Pugh scoring system, if it is under Child-Pugh score B or C in the class, we will adjust the dose of the caspofungin to reduce the dose of caspofungin from 50 to 35 OD, 35 mg OD. The maintenance dose will be adjusted. So in that cases, mainly in the echinocandin, we will prefer anudilafungin. That is, we will in the CLD patients, we can consider anudilafungin. But as in some patients, the cost will be very not much be tolerated. That's why we move on to caspofungin in some patients. So drug with significantly decreased metabolism in the CLD, that is drugs I have listed, that is chloramphenicol, erythromycin, verapamil, metronidazole, promazine, theophylline, and some drugs such as fentanyl, midazolam, amiodarone, which we are giving in the critical ill patients or in the ICU setup. Mostly, we should be more cautious. That is, the elimination will be very much be compromised in the patients like if they have CLD. And dosing in liver disease in CLD patients based on the Child-Pugh score, some of the antimicrobial dose should be adjusted. Some of them are tigecycline, caspofungin, which I have said earlier, voriconazole, daptomycin, and valproic acid. Sorry, the valproic acid is not a antimicrobial; it's an anti-epileptic medication. It should also be adjusted. And drugs should be cautious with, that is tramadol. If we are giving tramadol in a CLD patients, in normal patients, half-life is around 5 to 6 hours, but in liver cirrhosis patients, it will get prolonged to 30 hours, up to 30 hours. So should be very much conscious when we are giving the tramadol. But because in a patient, if the patient is having seizure or a seizure like if they have any prior history of seizure, or if they are taking any seizure medications, and we are continuing the seizure medication in the ICU setup also. If the IP patients, if we are giving the tramadol is a medication which will reduce the seizure threshold. So you should be very much aware of about that, because up to 30 hours our one dose of tramadol will be sustained in the blood of CLD patients. If we are giving repeated dose of, if it is about a 1 day, that is 24 hours or 1.5 day. So if you are giving a 3 doses of tramadol, more accumulation of drug will be in the body, and also it will reduce the seizure threshold, and it will be more chance to get the patient and seizure episode. So you should be very much aware about that. And the morphine in a normal patient, 3 to 4 hours of half life, and the liver cirrhosis it will get around 5 hours. It's more not much of differences. And the NSAID, if it is contraindicated in the liver disease because it's increase in the bioavailability and high risk precipitating GI bleed. And gabapentin is the first line non-opioid for analgesia in that conditions. And paracetamol is the one of the safest analgesic in the liver disease, and limit the daily dose up to 2 to 3 gram. Reduced dosing should be preferred. That is the reduced dosing. That is the lower limit dosing should be preferred in the liver diseases. And the case scenario, that is, John is a 58-year-old, 70 kg man admitted to ICU with worsening ascites and jaundice. His medical history shown he is non-case of CLD, secondary to hepatitis C, and type 2 DM, hypertension, because before this admission, his blood pressure was 140/85, and his WBC was 7,000, and elevated liver enzymes to 120 and AST to 140. Total bilirubin count of 4.5 mg per deciliter and INR of 1.8. Albumin is 3.0 deciliter gram per deciliter and HbA1c of 7.5%. During his stay, John developed signs of systemic infection, including fever, chills, hypotension. Blood cultures were taken and empirical antibiotics were started. And blood culture shows a Acinetobacter baumannii, which is a GNP NLF, that is a gram-negative bacteria, which coming under the non-lactose fermenter, which is resistant to carbapenem. So it can be called as crab, aminoglycosides, and the other antibiotics such as aminoglycosides, cephalosporin, fluoroquinolones, and are only susceptible to tigecycline. So what we can do? Does the dose of tigecycline to be adjusted? What will be the dose of tigecycline to be adjusted? Then what will be the dose of tigecycline? Yes. And what will be the dose of tigecycline? Loading dose 200 mg and maintenance dose of 100 mg BD. Loading dose of 100 mg, maintenance dose of 50 mg BD. And the C, loading dose of 50 mg and maintenance dose of 25 mg BD, and loading dose of 200 mg and maintenance dose of 50 mg BD. And which options we would select? That is option D. We will select. That is the usual dose of tigecycline for crab as per the IDSA guideline is tigecycline loading dose of 200 mg BD and 200 mg loading dose, that is and maintenance dose of 100 mg BD. So in this case, loading dose should be given the same, but the maintenance dose should be adjusted as per the Child-Pugh score, because when we calculate the Child-Pugh score, it comes under Child-Pugh score C. So 50% reduction should be done. So we will reduce from 100 mg to 50 mg, and 50 mg BD should be given to the patient. So I will tell an additional point that only tigecycline monotherapy is not indicated in the crab. That is, if the patient is having the culture positive crab, we should also give ampisulbactam, which is available in India, but in the IDSA new guideline, darlobactam sulbactam is said, but in the new guidelines, darlobactam sulbactam is not available in India. So ampisulbactam, tigecycline, therapy, that is a dual therapy, is more or triple therapy, or that is polymyxin B can also be added. So a combination therapy is more preferred in the IDSA guideline. So we should move on to the combination therapy. For the case scenario, I have said for, a monotherapy, which is cycling. And to remember, the liver and kidney are important for the body's ability to break down and excrete medication. Diseases of the liver or the kidney, in addition to age, can often require doses to be lowered in order to avoid ADR. Patients with markedly reduced liver function should avoid certain medication and dietary supplements. Moderately impaired kidney function may require lower medication doses, and severely impaired functions require avoidance of certain medication. And these are the references which I have taken, the data, which you can also go through. And thank you for that.
Thank you, Irfan. That was such an amazing topic, and I think so you've covered each and every point of it. And
Thank
there's
you.
so many, yeah, and there's so many aspects of the clinical pharmacist work in ICU, and the major chunk of it, I think so though you would agree with me, the major chunk of our work goes into renal and hepatic dose adjustments.
Yeah.
And to make sure like when the patient is such changes are happening in critical patient and so fast it can occur, the various renal replacement modalities happening and this plasmapheresis as well. So that point
Yeah.
also. So each and everything, I think so one clinical pharmacist should be looking over. And I think so amazing that you covered also the reconciliation. It's so important. I think the first step that you put in your ICU, the first thing that you go for is your medication history and the reconciliation part. I think so that is the step, the first very step. I think so one should look over. So, just wanted to ask you, Irfan, like, what are the commonest drugs that you see in ICU during your reconciliation? And during your rounds in ICU, that you find that you want to make sure that these drugs are checked for the dose adjustments.
First of all, I will tell about the reconciliation, and because when we look on to the patients with the renal impairment or liver impairment, first of all, we should know about that if they have taken any NSAIDs or ACE inhibitors or ARB. So then only we know that if it is drug related or something like that. And also, if the patient is having any hepatic impairment, we should move on to only not onto the allopathic medicine. We should also look onto the Ayurvedic, or not I'm bearing the Ayurvedic, but to the alternative medicines. We should also look onto the, because all the medications as the allopathy, the Ayurvedic, the homeo, all the medications have some constituents, that is which is affecting our kidney and also renal impairment. So you should be very much aware about that. And as Abde asked the question, the normally we look on to the antimicrobials mainly. We will look on to the antimicrobials, mainly the antibiotics, and also some of the antivirals are also very much important in that aspect, also very much important. And also like the IV infusions. IV infusions should be very much be aware about that. That is the propofol, fentanyl, and dexmed. All the IV infusions should also be very much be aware about how we are giving, because in the if we take on to the propofol like anesthetics, it is very much of lipid content. It is profile is very much increased. So the patients who are having very much triglyceride content or something like that, we should be aware about the IV infusions also. So we should cover all the aspects, not only the antimicrobials, not only the antivirals, also the IV infusions are also very much important in that aspect also. So as I have said in the obstruction part, the catecholamines are also very much important when we are looking onto that.
Yeah, absolutely. I think so. Some of the very notorious drugs, NSAIDs and everything
Yeah.
that we look forward to. And a great way, I think so. You have touched on this also explaining about the various pharmacokinetics of the drug is so important, and one should know about it. Uh, may it be the volume distribution or renal elimination, just like your case in TD cycline that it speaks about. No need to adjust the loading dose, but it's a maintenance dose that we need to look after, not affecting the loading dose anyways. So, Irfan, I would like to ask you, like, if any challenging case regarding this particular intervention in your renal dose or hepatic dose that you did, and that made a great effect in the patient's safety, right?
This is not about the dosing. I have when I in the first beginning of my career, or at the starting of my job, a patient came up with a patient dialysis patient came up with an prominent encephalopathy, which he is not having any. The intensivist and our multidisciplinary team is asking day by day, 2 to 3 days, what are the causes, what are the causes, and for the encephalopathy, no cause, no, there is no cause. We are getting any diagnosis for the patients. So first day I took reconciliation, but the patient bystanders only said about the normal, that is a normal routine medications and regular medications. The second day also I went to them, because my mentor, that is the Faris Hussain, one of my mentor, he asked me to go and ask the patient bystanders if they have taken any other drugs. Repeatedly I go through. The second day I also approached the bystanders, but they said no, no, they're only regular medication. But the third day I go with them, and I ask the bystanders, can you please come up with the that is strips of the medicine and also the prescription. And they came up with the prescription and the strips of the medicine, and I found out the baclofen medicine, baclofen. So when I look onto that, for a renal impaired patient or a hemodialysis patient, the baclofen is contraindicated, and it will affect that is the toxic level. It will get the toxic level, and it have an adverse event that it will get on to. It is a medication which is given for hiccups, and it will have a severe toxic. If it is toxic, it will get encephalopathy, that is severe encephalopathy, and it is a dialyzable drug. By God's sake, it is a dialyzable drug. And third day, which I approached my mentor, and I said that he's have taken the baclofen. I think it is I think it is by baclofen. Sir suddenly taken up the my the intervention and asked to get the dialysis order as fast as possible, and within 1 hour dialysis initiated. As by God's sake, the patient was prominently improved very much after one session of dialysis, and the patients improved, and the patient was discharged from the not from the ICU. They got a room, and from by 2 days, he got discharged to his home. It was an good case for me.
That's amazing. I think so. That's amazing case, and that intervention was very important. And I think so. I also had a similar experience with the baclofen being prescribed for hiccups again. And just when the patient was changing to AKI, so I had to intervene and stop the baclofen. So just I think so amazing those little bit of drug, those things, simple things. It could be a simple drug also.
Yes.
It could be a very known drug. So in ICU, that needs to be very careful one shouldn't.
Yeah, it is a simple drug, but it's very notorious.
Yeah. Yes.
So
In this case.
each and every point is important for us as clinical pharmacists. So we can make a big difference in this current scenario. And also in my institution, they are giving, and in my current scenario, they are giving very much of important for the clinical pharmacist. And I think we should be more capable, and we be more should be more attached to the drugs. And also these minute drugs will cause very much of ADR and toxicities, not only the antimicrobials.
True, true. Absolutely. So I think so we have had a wonderful session and such an amazing topic that was covered today. So thank you, Irfan. Thank you
Thank you,
for such
Abhay.
a wonderful presentation.
Thank you.